All right, Article 10.
All right, I have a headache. I have a little bit of a headache.
Oh, God, I hope
we
you don't
talking
have a
about
bleed.
Subarachnoid hemorrhage? No. Intracranial bleed?
Yes,
Maybe? Okay.
yes. Okay, so the topic is management of intracerebral hemorrhage.
Oh, there we go.
These are guidelines for the management of spontaneous
That
intracerebral hemorrhage. Guidelines.
Oh.
This, when it says guideline, it means it's at least a 20-page paper.
At least.
And this one happens to be 34 pages.
With a gazillion references.
With a lot of references.
Yeah.
So, sorry, we are
It's
going
actually
to
exhaustive. It has everything you'd ever want to know.
You'd ever want to know.
And
this
we're
was an
going to do it.
update from 2010, and this was in stroke. This was in 2015. This is all like need to know stuff. So I'm glad they put this one in there.
It's very substantive, this paper.
It is. It's got a lot of issues in here. We're going to go through them. So first of all, spontaneous intracerebral hemorrhage is a big deal. It's obviously a significant cause of morbidity and mortality. There's a bunch of different data that's been coming out about this recently. We know that actually, if you have a small bleed and you get good care, you can actually do pretty well.
Right.
A lot of these.
This is the hemorrhagic stroke we're talking about here, not subarachnoid, but hemorrhagic stroke
Correct.
concept.
We're talking about that percentage of strokes
that are bleeds.
And if you get good care and it's not a big bleed, you can do okay. Obviously, a lot of these are really, really devastating. And so we're going to focus on adults. We're going to focus on the management. We're going to talk about people on anticoagulants and reversing them and care and all that kind of stuff. It's a big deal in the ED to make this diagnosis because these patients tend to deteriorate quite a bit.
Really fast.
Really fast. In fact, they said about 20% of the patients between the time that you're picked up in the ambulance and the time you get to the ED, you're already deteriorated. So figuring this out is a big deal. And we know that. We see that. That's actually one of our signs that often I can think this is a bleed because they're just going downhill so fast. In terms of pre-hospital management, obviously airway management, cardiovascular support, getting people to a stroke center is the priority. And those are kind of common sense things. Knowing the history, when was the patient last normal? When did all this start? Making sure that the hospital who's receiving the patient knows that you're coming to make sure the CT is expedited, that they're ready for this very sick patient. And in terms of things that we might be able to do in the field that might make a difference, those are things being studied. We don't have a lot of evidence.
Right, and all this stuff is things that people are doing now, right? We know that time to lytics in the ischemic stroke has been a big focus. So all of these are pretty much automatic now, I think, for what we do with strokes.
So in terms of what we do in the ED, this is kind of a new section to the guidelines. We want to assess the stroke severity. And in terms of knowing what the baseline score, that could be very useful. We don't know exactly which scale to use. Should we use the NIH stroke scale? Should we use something else? We don't know the ideal thing, but the idea that you want to have a baseline score is probably useful. This is a new recommendation to kind of have a baseline idea.
I really wish they would have said, and here's the one to use, instead of use a score. It's like, oh, seriously.
Or maybe you could look at it this way, which is like use whichever one you're comfortable with, and that's okay with them.
So like thumbs up, thumbs down, like bad, good.
Yeah.
That's my score.
You want to get rapid imaging. CT is currently sort of the gold standard. We know that CT is very sensitive in picking up hemorrhage, so it's very good for looking at blood. MRI isn't bad either if that's what your protocol does, and there's special types of MRI that see blood better than others, so that's important to know. But these imaging techniques, the idea in a patient who is a stroke patient, you're trying to figure out if they fit into the ischemic box or the hemorrhagic box, imaging is going to be the thing that tells you.
Right.
So you've got to do that. And then you've got to get them admitted to a stroke unit. We know that stroke unit care is really important in terms of eventual outcomes. We want to have a plan for rapid transfer. If we need to transfer someone out to a tertiary care center, we've got to have a plan to do that and make sure that that can happen in the most efficient way possible. For the patient with the bleed, knowing neurosurgical resources, having neurologists, neuroradiology, critical care, all that backup stuff is really important, and they need to know about this patient early on. This is a critically ill patient, and telemedicine might be something that could be useful.
Especially if you're rural, this is very helpful.
Very helpful. In terms of the actual ED management, having a pathway for management is important. We know that protocolized care can often make a difference, so you don't forget all the little things that are important. There is one from the Neurocritical Care Society. If you need a guideline, if you don't have one and you're looking for a resource, there is one available for you to look at. Now, in terms of neuroimaging, we know that clinically it's very difficult sometimes to tell ischemic from hemorrhagic strokes.
We think we can, but we often can't.
We often make our bets before they go to CT scan, and sometimes we're right, but sometimes we're wrong. And so it's hard, sometimes it's really hard to tell. But getting that image, that picture is really, really important for lots of reasons. You talked about thrombolysis and ischemic strokes, and that a candidate for that. Well, certainly if you have a bleed, you're not a candidate. But it's important to know what's going on in the head. CT is the gold standard. There's a couple other things. You can do these T2 susceptibility, weighted MRI, gradient echo. There are some things that are also good at looking for acute bleed if that's where your protocol takes you. But most of us are doing a CT as the front line, as the first line test. Now, there are patients who are at higher risk for having their bleed, their hematoma expand. And there are imaging signs that can tell us this. So if your patient happens to get a contrast enhanced CT or you add on a CTA, you can look, for example, they talk about this thing called a spot sign, which is within the bleed itself, you see this presence of acute contrast. It's kind of like the blush sign.
It's like the blush in
It's like a
trauma.
blush in the head. The spot sign is saying this is someone who's at risk for this thing really expanding. And so looking for those signs is important as well, knowing that they can exist. What if somebody has an AVM or some kind of structural abnormality? That could be something that can be identified on imaging as well. And there's a lot of different techniques you can use, from CTAs and CTVs and MRIs and MRAs, and all those kinds of things can be useful. Probably the thing that's most commonly studied and we know about is CT angio.
It's easy.
CT angio is the most straightforward one. Now, in terms of their medical treatment, it's very common, up to the 20% number comes up to 20% of these patients are on some kind of anticoagulant or antiplatelet agent. And the more we're using these, the more this can be a consequence. 20% was the number they gave in the paper. These certainly, we know, can increase risk of bleeding or expansion of the hematoma. So managing those and knowing about those is crucial. For patients who have a factor deficiency, they have hemophilia or they have some kind of a platelet disorder, consider replacing those to help in terms of your therapy. For patients, some patients, you're gonna have to talk to a hematologist to get the best available
it gets complicated.
paper. It gets very complicated. If they happen to be on a heparin drip and they develop a bleed, protamine would be something that you should think about. Reverse it. For patients who are on vitamin K antagonists, so we're talking about warfarin type agents, and they bleed, we got to correct the INR. We got to do that as quickly as possible. What are the things we're going to use to do that? Certainly the most traditional option would be FFP. That's kind of your classic option.
Right.
Now we have the PCCs, the prothrombin complex concentrates. Those are also out there as a potential therapy. Recombinant factor 7, we're going to talk about how we're not going to use that, but that's also on the list of possible therapies. And then IV vitamin K. Don't forget about good old IV vitamin K. This should be something that you give for all reversal, acute reversal, and you have a vitamin K antagonist, give some vitamin K. It's 5 to 10 milligrams. You give it slow, intravenously, and it should have an onset within about 2 hours.
Right.
It's going to max out about 24 hours.
That's not going to fix it right this second, but it's what's going to reverse it down the line.
That's
so
right.
the warfarin doesn't sit around forever and do its thing.
FFP, remember, if you're going to use FFP, it needs to be cross-matched. It has to be thawed. There's risks with FFP, like any blood product. They can have allergic reaction. There's risk for infection. And really, if you're giving the right dose of FFP, it's actually a lot of FFP. A lot of
2
people,
to 3 liters.
2 to 3 liters. People order 2 units FFP or 4.
No.
It's not. That's not it. It's actually like a weight-based dosing, and it's a lot of FFP to actually
Right, you're
reverse.
replacing all the factors that are not there.
Right.
So you have to basically fill the tank, and that's a lot.
And that's a lot. And so volume overload in those cases, that's one of the big issues with FFP, not to mention the infection and transfusion
Thawing
reaction
and taking
and that
forever.
kind of stuff.
And
And so to really rapidly reverse someone's INR, it may not be the right answer. It could be insufficient to do that. So in walk the PCCs, which is a more relatively new therapy. There are 3-factor PCCs and 4-factor PCCs. These are concentrates. They reconstitute to only 20 or 40 mLs. So it's a much smaller volume.
Powder in a bottle.
Just a little reconcentrated and boom. You don't have to cross-match it. There's no infectious risk. You can give it rapidly. And so that can really normalize your INR within minutes. So it's a really fast way to go.
And it's approved for reversing warfarin.
So this is great. So PCCs, yes, thumbs up. 2 thumbs up on that one.
And that's if you have choices of things to give, that's a definite.
Yes. So although it rapidly reverses your INR, in terms of it being better than other reversal options, can't really say that that's the case. And recombinant factor 7A, as mentioned, this is not recommended for this particular indication.
Right. And this paper talks about these are the things you're supposed to be doing, but there's not a lot of evidence that you change outcomes a whole lot with these. You make numbers better.
Yeah.
But there's not a lot of evidence of changing outcomes.
You know, once the blood gets out into the brain, you can give all these things, but it's not really going to fix the long-term outcome. But we're still going to do it. We're still going to do it.
Absolutely.
Now, we have so many patients that are on new anticoagulants, all the NOACs, the fancy schmancy stuff. And so we don't have...
and the Itrans and the,
There are just more and more and more patients. We don't have RCTs to tell us what works for these patients or what can make a difference. There's very, very little evidence.
There's a lot of talk and no data.
Yeah. The good news is that most of them have pretty short half-lives. That's a good thing. They range from like 5 to 15 hours in terms of their half-life. So at least they can wear off more quickly. That's a good thing. There's no blood test that you can send that's like a routine thing that's going to tell you much. In terms of if this happens to you, talking to a hematologist can be really useful. And maybe they're going to have you send things like PTT and PT. And, these are all reasonable things to do with a critically ill patient who's on one of these newer drugs. reach out for help. No one's going to blame you for doing that.
Absolutely not.
Yeah.
Absolutely not.
Get some recommendations.
Yep.
Get someone else on board to help you guide you through these waters.
It's complicated stuff.
It's complicated stuff. What we do know about these newer anticoagulants is that giving vitamin K isn't going to be useful.
None.
Giving FFP, we're not sure that helps. And if they had taken their drug, if it happened to be that you had the history that they took their anticoagulate within the last couple hours, maybe giving activated charcoal might be an option. I mean, that's how desperate we are.
Exactly. That's people sitting around the room saying, "Can anything work? Let's drag out the old charcall again."
I don't think I'd give activated charcoal to someone who could aspirate it, but just think about it.
I don't know about that. That's true.
Dabigatran, you can dialyze, so maybe dialysis would be an option.
That'd be an interesting phone call to your renal person.
Yeah, for dabigatran in particular, you're reaching for some stuff here. You're talking about maybe the recombinant factor 7A. You're talking about this Phoebus stuff. There's some other weird stuff out there. For the other factor 10A inhibitors, maybe PCC might be something you'd think about.
And this paper came out before the reversal agent came out for
yes.
the dabigatran.
So we know dabigatran has this new reversal agent. This paper exactly. It came out before that. So it doesn't talk about that in this paper, but that might be something that
in real life.
In real life, you might
the ABEM world right now, which is
right.
it doesn't exist, but in the real life it exists.
In Article 10 world, it does not there yet. How about someone who's on an antiplatelet medication? They're on the clopidogrel. Exactly. In terms of also at the time of this paper being published, we didn't know a whole lot about what to do with them. And, we know that giving platelet transfusion, what they talk about in the paper is that giving platelet transfusion within the first 12 hours, it might make the growth of the hematoma smaller in those people who are at high risk for expansion, and maybe it would help those people. And at the time this paper was published, they knew that there were studies going on looking at the use of platelet transfusions, and that everyone realized that giving knee-jerk reaction to giving platelets might not be the right thing to do. And we've had some newer evidence suggesting that's not the right thing. Not the right thing to do. We know that now, but in the world of Article 10,
in the ABEM world, we don't know.
Yeah, we didn't know. Recombinant factor 7A, it's very, very expensive, and it's a big no.
It's a drug looking for a reason to exist anymore.
It sure is. I mean, I guess there's some people with very specific hematologic disorders that this can help. But in terms of giving it as a solution for something like this, not recommended. There's really no evidence of any benefit, and they clot. It's going to make you clot.
Yeah,
so
not good.
Just make the problem worse. Now, these patients, once the bleed happens, they're at very high risk for getting clots, for getting DVTs, et cetera. And so how are we going to prevent that in the person who has had a bleed? What are we going to do to help prevent the clot?
It seems so counterintuitive to be thinking about preventing a clot when they've just bled into something.
Exactly. Where does that balance lie? But we have to think about now we're after the clot, what can we do to make their lives as best as possible?
Yeah, after they've bled, right.
Leg squeezers. Leg squeezers is something that's, we don't have to infuse another drug and make things more complicated. Let's use the leg squeezers. That will help decrease the risk of proximal DVT. Now, once you actually know that they're not bleeding anymore, you can start things like enoxaparin or your heparin in terms of reducing PE. It doesn't significantly reduce mortality. We don't think it reduces the risk of DVT, but it's something that you could do. Once again, it's documented they're not bleeding anymore.
Yeah, exactly.
Right. If they do develop a DVT or PE, you're going to have to do something about it. And so you're going to have to weigh the option of systemic anticoagulation or think about something like an IVC filter. That might be something mechanical that you could do.
Right. And this, again, remember, this is a guideline from the neurology, that group. So this is really something usually out of our bailiwick, but it's something to be aware of the decisions that go with this.
Good use of the word bailiwick.
Bailiwick, huh?
Yeah, like it. Okay. So blood pressure. What do we do with the blood pressure?
Oh, this is like always the bazillion-dollar question, right?
It's the Goldilocks. If we lower it too much, we're going to stroke them out worse. If we leave it too high, they're going to bleed too much. So what do they want us to do?
Whatever we do is going to be wrong. So we need to know the guideline.
Yeah. It's super common for them to have these patients to have elevations in blood pressure. We know that that's bad. If they're pumping too hard, they can expand their hematoma. They can get worse, et cetera. We want to also minimize the ischemic penumbra as well. So in terms of studies that look at lowering blood pressure, we think that this probably does improve outcomes. It doesn't seem to cause harm to lower the blood pressure in this particular circumstance.
Right. This is the bleed.
This is the bleed.
Yeah,
so
not the ischemia. This is the bleed.
This is not ischemia. This is the bleed. So probably turning the volume down a little bit is okay. And some of these papers have gone as low as 130 millimeters of mercury systolic. So now the evidence suggests that, yes, we should be doing intensive lowering of blood pressure early on. This is safe. It's feasible. We think they do better functionally, which is an important patient-oriented outcome. And so the recommendation is if your systolic is up in the 150 to 220 range, get it down to 140. Bring it down to kind of the upper limit of normal there. Get it down there. If it's over 200, you should be going IV agents,
really
get it down. Get it down. Get it down. That is too high. That is too high.
And it's often that high, right? In the
It's
bleeds.
often that high in the bleeds. They've got a lot going on. They're hypertensive patients to begin with. Sorry. Okay, so in terms of preventing secondary brain injury, we've got the bleed that's happened. Let's not make it worse. What are some things we could do? Dedicated stroke units are preferable to ICUs. Having people who are doing the swallow eval and know about stroke, that's probably better. The nurses can be specifically trained and specialized in taking care of stroke patients, including hemorrhagic stroke patients.
And the data on these places is pretty darn good. People do. I want to go there if I have a stroke.
Exactly.
Please send me to a stroke unit.
These days we're focused a lot on IV thrombolysis and thrombectomy. Let's not forget that stroke units make a huge difference for all comers. We're not picking and choosing people, time windows and types of clots. This is actually all stroke patients can do better on a stroke unit. What about glucose management? Do we want to be, what should we be doing with that? Well, we know that letting the sugar ride too high is probably a bad thing, and that worsens outcome. But we also don't want to be tinkering with it too much that we drive it low, because that's also bad. So there's not a lot of consensus about what to do. No one really knows what to do.
I love this, but avoid hyperglycemia and avoid hypoglycemia.
Yeah, but don't play with it too much.
But it's like, okay, well, I don't know what to do with that.
So
Thank
there's not
you
much recommendation on glucose. What about temperature management? Should we be cooling them? What should we do? We know fever's bad, so let's prevent hyperthermia. That worsens outcomes, but we don't really know much else. We don't know that, just giving normothermia, just maintaining that doesn't seem to make a big difference. Hypothermia in terms of bleeds in the head, pretty investigational. So, let's just prevent fever. That's a take home there.
That one's easy.
What about seizures and anti-epileptic drugs? We know that seizures occur in a decent number, 16% of these patients, usually at or near the onset of the event. We know that giving prophylactic seizure medications decreases the risk of seizures, but we don't know the association between the seizure and actually how they do, because it's there's a lot of confounders there. So does the seizure actually make things worse? We're not really sure. So we don't think that giving prophylactic anti-seizure medication before they've even had a seizure is something that you should be doing.
Right. So if you've had one, fine. If they haven't, don't just grab the click of your mouse.
Exactly. So just seeing the bleed in the head doesn't mean you should automatically write for anti-seizure medication.
I think that's actually a pretty common practice.
It is a common practice. So know that is not the recommendation to do that.
And this is something, if they were to ask a question about this and that is your usual practice, you're probably doing it. According to this guideline, you're not doing it the way you're supposed to.
So no seizure, no seizure drug. Now, about these seizures, people can have subclinical seizures. A lot of these patients, when you put them on an EEG, they actually are having some seizure activity.
That's just so unfair.
I mean, what that means, we don't know. We don't know what that means. And studying this kind of stuff in this patient population is really difficult because their outcomes are poor for so many reasons. What did it have to do with the seizure or the drug? Who knows? So, but we do know that if you see a seizure or you happen to have an EEG that shows seizure activity, those people you're going to treat. And if you're not sure, get an EEG and check if they're having seizures or not. But you only give the drug when you have a reason to give the drug. And that might be EEG based. That's okay too. These patients have a lot of medical complications. The number one thing, the most common thing is pneumonia. And so that's one thing to know. That could be a test question. The most common thing is pneumonia. Along those lines, down the road is aspiration, respiratory failure and distress, PE, we talked about their clot risk, and sepsis. They have swallowing problems. That's where the pneumonia and the aspiration come from. So that's why stroke units and doing swallow studies is really important, because these are the complications. And 50% of the stroke deaths are due to complications. Cardiovascular events happen too. They can have MIs. They have risk of CHF. There's this thing that's called neurogenic pulmonary edema. You get some kind of CNS insult, all of a sudden your lungs get super leaky and they start giving you pulmonary edema problems. And so that might be something that you have to deal with in terms of airway management. So overall, in terms of recommendations, these medical complications, you want to do a swallow study, do a screen for dysphagia before you're starting to feed them, to prevent that pneumonia and aspiration. And it may be indicated in some patients to do some screening for MI or ischemia. Certainly getting an EKG would be warranted. And maybe you're going to do cardiac enzymes if there's something to worry about, because they have that too. That's a big complication. What about putting in intracranial pressure monitors.
Yeah, stick a little tube in there.
Stick the tube in there. Check the pressure. Check the oil gauge.
Yeah.
Yeah. Well, if they've got hydrocephalus, certainly ventricular drainage is reasonable, and that seems a common sense thing. Also, if they're doing really poorly, this might be another indication that they need an ICP monitor. So if their GCS is really low, there's signs of herniation, there's really big hemorrhage or hydrocephalus, that might be someone who's going to get an ICP monitor or treatment. And we want to make sure that we're getting a good cerebral perfusion pressure. CPP should be somewhere in the 50 to 70 range. Steroids are off the list. Don't be giving, there's really no role for corticosteroids in terms of preventing swelling or elevated ICP. You might think that steroids could make a difference. They don't. So steroids are off the list. Now, unfortunately, almost half of these patients, 45% of them, get intraventricular hemorrhage. And we all know that when you see that, it is not good. And it is very hard to manage that. It's associated with obviously a poor outcome, risk of death. Putting in one of these little catheters, it doesn't help because it clots up.
It makes complete sense.
It just
right?
does. Yeah,
it doesn't suck
work.
out anything.
It doesn't suck out anything. The blood clots up. Even they've looked at trying to put thrombolysis in that little catheter, and maybe you could bust up the clot and drain it. It doesn't. None of that stuff helps. It just doesn't help. So while that might seem like something to do, we really don't think that makes a difference. Maybe could you do something endoscopically? That's under investigation. Who knows? In terms of actually removing the clot, they've bled, they've got a clot in there, should we go in and get it? There's not a bunch of benefit that's been demonstrated from that. Yeah. So there's really no clear benefit of that over the things that we conventionally do. Maybe some patients in some subsets of some trials benefit from that, but we don't really exactly know who those people are. So the recommendations on whether or not you should be doing clot removal, or obviously you're not doing, if the neurosurgeon should be engaging in clot removal, you punt this one, and there's literature for them to know about. We don't need to know about all that. Yep. Just know that there might be some people that they choose to do that in, but that's not something that we're going to get
above my pay grade.
Yeah, that's right. We do know that posterior fossa bleeds are really bad. Cerebellar hemorrhage is awful. They deteriorate. They have no room in there, and so their brainstem gets compressed. Brainstem's important. We kind of need that's sort of our primordial stuff. We kind of need that, and they get hydrocephalus, and so that's really bad. If they have a posterior fossa bleed, that clot's going to come out a lot sooner than other clots, and that might be because it's just measures of desperation at that point in terms of what you can do. There's no role for ventricular drainage in the posterior fossa bleed. What about supratentorial spontaneous bleeds as well? Surgery there, who knows? Who knows who's going to, again, these are sort of subgroups, and your neurosurgeon is going to make some decisions here, but we do know that going in early and sucking out the clot doesn't really seem to help. If they're doing poorly, maybe your last shot is to try to evacuate the clot, and maybe decompression is something when someone who's in a coma and they've got a huge shift. These are people who might get craniectomies, craniotomies, things like that to try to evacuate the clot. Now, in terms of predicting their outcome, in terms of the existing models to do that, they're pretty limited in terms of knowing how they're going to do from when you see them. If they don't have an advanced directive present before the event, the recommendation in this guideline is to do aggressive care at least until the full second day of their hospitalization.
Which is interesting because we all have been in situations where the neurosurgeon comes down, kind of rolls their eyes and says, there's nothing I can do, and then leaves.
That's right.
And just lets them sit.
Yes.
Nothing else happens. And so their own guideline says, don't do that.
The guideline says they should be basically get full court press for at least 2 days. And then you can start talking, where we're going from here. Unfortunately, if they do survive, there's recurrence, and that's, in the first year, it's a 1 to 5% risk alone of recurrence, and that's the highest time in that first year. The risk factors for that are things that you would come to mind: hypertension, older person, certain locations of their bleed, if they're still taking anticoagulants, and certain genetic factors that can influence that as well. One thing that we can do is control their blood pressure, keep their systolic below 130, keep their diastolic below 80, kind of a lower threshold to make sure they stay at that lower range and prevent recurrence, we hope. We've got to make sure they're not smoking. There's lifestyle things that need to be done. Don't be using cocaine or things like that. That's not going to help. Keep the booze down to a minimum. If you got sleep apnea, let's work on that.
Get a machine.
Get a machine. And, if you don't need to be on anticoagulants and you don't need to be taking warfarin, let's not go there if we don't have to go there. And in fact, that risk versus benefit risk of anticoagulation, you've really got to think about after they've had it. You've crossed that threshold where we got to really think about why you're on that anticoagulant and look at that. That's an issue as well. If they've had oral anticoagulation bleed, that's even, just make sure that we're really thinking about that.
This is such a logical recommendation.
I know.
If you've been on an oral anticoagulant and you bleed,
and you had to bleed in your head,
you shouldn't be taking them again.
Yeah, that's probably something you shouldn't do again. Yeah. Yeah, consider that almost like an allergy.
Oh,
like you
okay.
just shouldn't be taking that again. Don't do it. Now, in terms of rehab and recovery, again, multidisciplinary, interprofessional teams.
There we go.
Interprofessional teams is recommended. And you should be getting them out of bed if they are well enough to get out of bed. Do it as soon as possible. And you should pair this with some accelerated protocols to get them out of the hospital as quickly as you can.
Because hospitals are bad places.
Hospitals are bad places. You got to get them home and get them into their therapy and kind of push that envelope a little sooner. They're not getting better lying in the hospital bed.
Not at all. So now the bazillion summary slides.
So the summary slides, we're going to revisit some of these concepts and sort of boil it down. In terms of the emergency diagnosis and assessment, you want to get some kind of baseline severity score. Use whatever score you like. If you use the NIH stroke scale, whatever it is that you want to use. You're going to get pictures quick. Get some rapid neuroimaging. CT is your gold standard. MRI can also be useful. CT angio could be very helpful in terms of looking at the risk for hematoma expansion and if there's any structural abnormalities. So you may be, as you see the bleed on your plain CT, reflexively ordering a CTA to assess some of these other things. Patients are often on anticoagulants and antiplatelet agencies. We want agents.
I think they're agents.
Antiplatelet agents. Certainly patients who have factor deficiencies or really low platelets, you're going to give them the appropriate agents.
Refill that tank.
If they're on a vitamin K antagonist, which would be warfarin, and their INR is elevated, don't give them their warfarin. Okay, that's A. You can try to get those factors back in them, give them IV vitamin K. If you've got PCCs, that's probably the way to go.
Right, replete them.
New anticoagulants, the NOACs, this whole group, it's going to be very individualized as to which agent they're on, and you're going to need help. Reach out to your hematologist. There are some different agents that can be used. Consider things like activated charcoal for any of them, and dabigatran in particular could be dialyzed. If someone's on a heparin drip and they develop a bleed, protamine is your answer there. Patients who are on antiplatelet agents, your clopidogrel and your aspirin, at the time of this study, use of platelets was uncertain. So at this point, your answer would be, we don't know. Don't use recombinant factor 7.
It's still looking for a place to be.
Looking for a home. It's very expensive.
No.
Doesn't have a home here.
Not in this situation.
Move on.
No.
These patients are at high risk for clot. Use leg squeezers. Intermittent pneumatic compression devices is a good idea. Once we've proven they're not bleeding anymore in the first 1 to 4 days after their event, you can start things like sub-Q low molecular weight heparins, things like that. If patients do develop a DVT or PE, you're going to have to weigh the cost and benefit of systemic anticoagulation, but IVC filter might be also
a good option.
Blood pressure management. If they are riding high on the blood pressure, you want to bring them down. If they're up in the 150s to 220s, get them down to 140 systolic. If they're riding a high above 220, that is IV time. We're going to bring them down, get aggressive, and get it down and monitor them. Certainly patients are going to be going to an ICU, or even more preferable would be a specialized stroke unit. Lots of benefits there with nursing and physician expertise. In terms of glucose, you don't want to be too high or too low. We know that that's
Goldilocks.
bad, exactly, and certainly we want to prevent fever. That would be a very reasonable thing to do. Seizures, we're not going to give prophylactic anti-seizure medication, but if they have a seizure, whether it's clinically or on EEG, we will treat it with anti-seizure medication. And if we think that they're more out of it than what we see on the scan, then a checking of an actual EEG to see if they might be having subclinical seizures would be a very reasonable thing to do. Medical complications, right up at the top, are respiratory things, pneumonia, aspiration. So we want to do swallow studies, formally screening for dysphagia before we're letting them do any kind of oral intake. And then think about the fact they're also at risk for cardiovascular complications, screening for MI and ischemia, using EKG, cardiac markers is also very reasonable. In terms of intracranial pressure and ICP monitors, these are very common devices that we consider in the care of these patients. These can be reasonable in some situations. Hydrocephalus, yes, go ahead and put the drain in. Something really bad's happening, they're going down the tubes, they're herniating, the GCS is dropping, there's hydrocephalus. Those are things that ICP monitor is reasonable. Cerebral perfusion pressure, we want to be in the 50 to 70 range. No role for steroids.
Nope.
In terms of intraventricular hemorrhage, which is unfortunately a complication in many of these cases, it's a very bad outcome. What to do about it is not clear. Putting in a catheter and getting it all clotted up, doesn't work. And so maybe there's endoscopic things that we can do, but right now the answer is
nothing.
Nothing. That's just a bad sign. Cerebellar hemorrhage, things in the posterior fossa, very bad. These things need to be attended to very quickly. They can go down the tubes neurologically. They can have brainstem compression, and they need to have that clot removed surgically as soon as possible. And there's really no role for ventricular drainage there. Supratentorial hemorrhage, we're not sure if surgery can be helpful. There's a couple exceptions there. Basically, if somebody's dying, that might be something that you try, and maybe it helps some subset of patient. Your neurosurgeon will decide. In terms of prognosis, we don't have a good model that helps us know from the get-go how this patient's going to do, and so therefore the recommendation in this guideline is if they don't have an advanced care directive, that tells you what they want, then you should be doing full court press for 2 days before you make any big decisions. All patients should be going to comprehensive rehab, and there are a bunch of recommendations in terms of minimizing the risk of recurrence, which these patients are at risk for. Blood pressure, lifestyle treatments, and then depending on the circumstances and the type of bleed, there might be other specific things that pertain to them.
Big paper, lots of information, but I think most of it pertinent to our practice and things that we should know, and a few things that might be different than what you're doing in your practice now.
Yep.